So right now we currently are a group of 3 midwives, and Moriah, you make the 10th OB, right? And 10
Yes.
OBGYNs. We work out of, or we catch babies at Mission Hospital and Mission Viejo. We all kind of work collaboratively together. A lot of clients will come and see the midwives because they want to have different birthing options. We have a couple of options, just the standard labor and delivery option for maybe a little bit more higher risk, or women who have come in and decided that they want an epidural from as soon as they can get one, but they still want the midwifery model of care. So we do that, but we also have birthing suites that are called the midwifery suites, which is kind of a separate contained unit with 4 midwifery suites that we offer hydrotherapy, so you can get in a tub while you're laboring, use a shower, move around. It's less interventive, so you're not strapped to a monitor the whole time. We don't routinely start IVs. You can eat and drink as you please, move around, and really kind of let your body do that physiologic birth if that's what you choose. So we see you prenatally. We have 30-minute appointments, so we can really spend time with you, educate you, get to know you, form a bond so that it's not a stranger showing up at your birth. And we also do well woman care. So we take care of all your needs. If you need birth control, if you just need your annual PAP, if you're having any issues, we can take care of all of that as well. Anything to add, Leah?
I think you covered it. One thing I wanted to say was this webinar, with all our webinars, we have slides and presentation to show you, just something that can guide us along so that we cover all the material that we want to. Today, we're going to talk about the immediate postpartum period, what happens right after birth, which is something that we don't get to talk about a lot, kind of prenatally. And well, we try to, but it isn't talked about enough. So we wanted to create this webinar as well. But one thing that's really important to us, the slides aren't long. There's not a lot of it. So it's not going to be an hour-long lecture that we give. We just want you to ask questions and be open and feel comfortable to say what you need to say. And also, if you have any other questions that are unrelated to the topic that we're discussing today, feel free to ask anything. That's all.
All right.
So can I share my screen? Yes, thank you, Chelsea. You did that automatically without me even asking. Let's go to present mode. So what happens in the immediate postpartum period? Christina's going to start us off.
So right after you birth your baby, the first thing we do, if everything's uncomplicated and baby seems to be fine, the baby will go straight to you initially. So usually right on your chest or your abdomen. And this is really to start facilitating that bond between baby and mom, right? So really all of the assessment that the nurses do and the midwife or doctor does can all be done with the baby still attached to you and on your chest. Cochrane is kind of like this big medical model that they do. They get lots of information from multiple studies and do like kind of a huge study, but they did a study on the evidence for skin to skin care. And mothers were 24% more likely to still be breastfeeding at 1 to 4 months after birth. And the rate of exclusive breastfeeding between 6 weeks to 6 months was about 50%. And that's really because we initiated that bond right after birth, putting baby right to you. Babies held skin to skin with their moms were 32% more likely to successfully breastfeed in that first feed, which, babies do a lot of work in labor too. It's just not mom. They've got to navigate the birth canal and they're getting squeezed pretty frequently. So it takes some, blood sugar stores from the baby. So it's really important to get a good feed to get the baby's blood sugar levels to a normal level. If babies don't feed well in those first, that first day or so, sometimes babies need to be supplemented with some formula. So if we can do everything we can by putting baby skin to skin to prevent that, then that's just another bonus. Babies had better combined scores for heart rate, breathing, oxygen levels in that first 6 hours of birth, less anxiety, and I think that's both for baby and mom. And then less engorgement pain within the first 3 days postpartum, if you initiate all of that sooner rather than later. And then the next thing is delayed cord clamping and delivery of the placenta. So us midwives were kind of big proponents of delayed cord clamping. So the total volume of blood in the umbilical vessels and placenta is 25 to 40% of the baby's blood volume. So it makes sense, right, to let that blood go back to baby and not waste it. So there was a trial of 500 term and preterm infants. None of the babies showed symptomatic polythysemia. So that's when kind of you have an excess of certain blood cells. And the theory, I think, before was if we let all of that blood drain into the baby, that we were kind of increasing risks in baby, and they found that not to be true. Babies sometimes have a little bit smaller of an increase of jaundice, and they need to be under those like Billy lights. And maybe you guys have seen pictures where sometimes babies have blankets on them to kind of break down some of those blood cells, but I don't see that very frequently. And then ACOG, which is it's American College of Gynecology, of Obstetrics and Gynecology. They're kind of like the big wigs of our field. They state that umbilical cord clamping increases hemoglobin levels at birth, or delayed cord clamping increases hemoglobin levels at birth and improves iron stores in the first several months of life, which is favorable for developmental outcomes. So timing, I think that's all over the place a little bit. ACOG and then the Pediatric Society say we should do at least 30 to 60 seconds of it. I'm not sure who RCOG is. Leo,
Royal College of Obstetrics and Gynecology, that's Britain. England.
They say at least 2 minutes, and then the big Midwife Society says 2 to 5 minutes. I think us midwives, and I know we all practice very similarly, we usually, if we can, we wait until that cord stops pulsing and it kind of turns that white color so you don't see any more blood in it. We give the baby everything.
Yep, if baby's transitioning well and everything's okay and baby can stay skin to skin with mom, then yeah, we just let it go.
Yep.
Next slide.
And then, the next thing that usually happens once we do detach you and you become separate, we get you into a position where you can start initiating that first breastfeeding, and the sooner the better. In the 70s, Anne-Marie Widstrom, she was a Swedish nurse midwife, began to observe and document patterns in the behaviors of babies that were placed right on the mom's skin. She discovered that if we just left everything alone, that babies are eventually going to find the nipple and start breastfeeding, right? But it's this whole thing that happens. The baby cries, the baby relaxes, kind of gets this kind of alert, awake period, and where they're moving around and they're active, then they might rest and they start kind of like a breast crawl. And this is truly if you just left baby alone and didn't bring baby to the breast or anything. Eventually, they're going to kind of crawl up to that area. They will familiarize themselves with the nipple and kind of like they'll root around and kind of smell. They can smell these things. And then they'll probably start latching on their own and suckling and have a good feed and then go to sleep.
Yeah, it's amazing to see. It doesn't happen. I don't see it a lot in the hospital setting, depending on the nurses that take care of it and depending on how well informed you are about the breast crawl and how much you want to really do it. There are a lot of hands on the baby with drying the baby and stimulating the baby and all that stuff. Sometimes we need to advocate to kind of just let it be. Everything's okay. Just let it be.
I feel too, a lot of times we really kind of help initiate that first latch anyway, so we're not as patient, but it's also, it's such a great bonding thing for mom and baby just to get that going.
Yeah,
That's also amazing to see. So
absolutely. Okay, so bleeding, what to expect. I mean, we're always, I don't know if you guys know what happens immediately after birth, but we are, and it's normal, and we are expecting there to be a little bit of bleeding. So depending on how much there is, we tend to be more either expectant management or more actively managing it. So bleeding, postpartum, the official name of it, the medical term is lochia, if you ever hear that word. And there's normal bleeding right after a vaginal birth. Actually, up to 1,000 cc's is considered normal. And what to expect in the postpartum period up to 6 weeks. So in the initially you have quite a bit of a heavy bleed in the first few days, about the first 10 days, and then gradual decrease in the bleeding. What we are expecting there to be is always a decrease in the bleeding, and we'll show you right after the placenta detaches from the uterus. Those are all the blood vessels that are actually open up, and why the uterus needs to contract, because it closes off all of those blood vessels that are bleeding. So initially there's a big surface area where the placenta used to be that causes that heavy bleeding. With some massage and with the uterus contracting and with breastfeeding and all that, that uterus clamps down and contracts and closes off all those blood vessels. And eventually the bleeding does stop. So yeah, heavy bleeding at first, and then depending on if it's brisk bleeding right after delivery, we would either monitor you and see how it's going, and then check the uterus to see that it's nice and firm. If it's not, we may offer some medications. We usually talk to you about the things that we're thinking of. Us midwives, we're very vocal about the things that we're kind of just the plan and what we're thinking of, and because we don't want to spring things up on you and say, hey, I'm going to do this just because I said, and that's it. We kind of have a discussion, and we tell you what we're thinking and what our options are. That being said, of course, there's a little caveat there. If it's an emergency and we need to act fast, then things are happening fast and we're talking fast with you, but we're always kind of getting your consent for things. So just a long story short, the bleeding normally lasts about, textbook is 4 to 6 weeks is normal, but on average, most women bleed about 2 to 3 weeks. And really the key thing is to see that gradual decrease in the bleed. Warning signs would be, we would talk to you about if there's heavy bleeding, if you're filling up a pad, like a maxi pad within an hour. And if that's been happening for 2 consecutive hours with you just taking a rest, then we need to see you. Usually your body's way of telling you that you're doing a bit too much is by bleeding. So postpartum, when you're home and your bleeding starting to decrease, and all of a sudden you had a day where you just had to clean and had to do the dishes and had to host some family and had to do all these things, all of a sudden you'll feel some weakness and you'll feel that your bleeding is getting heavier, and that's just your body way of telling you, hey, take it easy. So warning side would be just what I said right now, the heavy bleeding and the filling up a maxi pad within an hour. And if that's happening within 2 consecutive hours, then definitely give us a call. And if you see large clots and things like that, if there's foul smelling lochia, that may mean that an infection might be brewing. And especially if you have other systemic symptoms like chills and fever and other things. So all these things, we would rather you call us or call your provider sooner rather than later, and not wait for your postpartum visit. Really important, especially those providers that see you only at 6 weeks. We want you to call us with any concern or any question. Tearing. Now this is a big one. This is usually one that we don't talk unless somebody brings up, should I do perineal massages, or how do you prevent tearing in a vaginal birth? So here we go. Most common tears are 1st-degree tears and 2nd-degree tears. These are located in the vaginal perineal area, so just at the introitus, at where the opening of the vagina is, and the area of your perineum, which is the area between your vaginal opening and the anus. Those are most common. Some tears occur on the labia, so on the vulva itself, periurethral, meaning around the opening to the urethra where you pee from, or periclitoral, which is around the clitoris. Those are a little bit more painful and more sensitive, obviously, because there's a lot of nerve endings in that area, but those are more uncommon. What the midwives do to help to prevent these tears is different positioning in the pushing stage. We use warm compresses, we do perineal support, and we need to scratch this mineral oil out because we don't use that in the hospital. I don't really know the reason why the hospital doesn't provide mineral oil anymore, but they found there was this article that came out saying that it's a little unsafe. But what we can, a substitute for that is that we tell you to bring your own oil from home, and we can use that definitely on your perineum. Perineal prep in the prenatal period can be performed by yourself or your partner, or a pelvic floor PT if you're seeing one prenatally. There has been some studies that's been, actually there's one big study with over I think right under 2,500 women, a few studies that were combined, and they saw that for women who are first-time moms, so pushing a baby out for the first time, perineal prep might be more, perineal massaging would be more beneficial. I think the decrease in perineal tears are by 10 to 16%. So, I mean, not a lot, but there is some benefit to it. So if it feels good, if it feels okay, and you want to do something, feel that you're a little bit more proactive about your perineum, then we say, go ahead and do it. And we can teach you how to do it too when we talk about it in the prenatal, in our prenatal visits. Pericare. So this is a few hours after birth. This is right before you're going home. So you're basically your 24 to 48 hour stay in the hospital. We talked to you about Pericare. So you get a peri bottle in the hospital, which is this nice squeezy bottle that you take into the bathroom with you. You fill it up with warm water. And as you pee, especially if you tore a little bit, those stitches and that tear can sting. And when you kind of squeeze that peri bottle with the warm water as you're letting go of that urine, that feels so much better. It makes a whole lot of a difference, and just makes your bathroom visits a little bit more tolerable. And also just with having a bowel movement, they help too. I must say that a tip that I usually do, I don't know, Christina, if you talk to our patients about this too, when you're counseling them about going to the bathroom and having a bowel movement, because everybody, especially those women who have a little bit of a tear, are so afraid to go to the bathroom for the first time. We tell you, don't hold it in, because we don't want you to get constipated. We do give you some stool softeners just to make sure that that first bowel movement is nice and soft. But a nice tip that I like to say is if you get a washcloth or a pad or something to support your front, so you support your perineum, as you're kind of letting go of that bowel movement in the back, that helps tremendously. It just supports it. You feel less of a stretch and less of a strain on your perineum, and especially if you have stitches down there, it can really help. Herbal sitz baths, those can feel really nice if you have a tub at home, or just get a small little basin that you can sit in, just either in water, or there are herbal sitz baths. There's actually kind of satchels that you can buy online or at any store. Actually, now they have them everywhere. I think even CVS carries them, where they have lavender and calendula and all these different herbal concoctions that you can put in the sitz bath to help you with healing. Those we usually recommend doing that for 15 minutes a day, not more than that, just to promote some blood flow to the area and heal. Same goes with herbal sprays, so same as that. And we do provide lidocaine spray for pain relief at the hospital. So if you don't have an allergy or sensitivity to lidocaine, that can definitely be beneficial, and just helping you move around and going to the bathroom and all of that. Avoid straining. I think I mentioned that with having a bowel movement, super important. And also just protecting that pelvic floor. There we go. I did put it in there. Support your front while letting go in the back. That's what I meant with the washcloth or the pad. Always pat yourself dry, no rubbing with the tissue or with whatever you're wiping yourself, just to not to pull any sutures or anything like that. And super, super important is just proper self-care, which is eating healthy and staying well hydrated and making sure that you are just taking care of your body so that it can heal and recover postpartum really well. Usually with the midwives, what we do is we see you twice because we feel like seeing you at the 6-week as a 6-week visit is way too late if anything is going on. So we just kind of like to touch base with you at 2 weeks. Usually if you feel fine, physically fine, you don't really want to leave the house with a newborn, we can do a telehealth visit with you. But we do love to see you and your babies in the office, and we like to help you with breastfeeding if there are any breastfeeding issues, or just kind of walk you through any emotional changes or anything like that that you're going through, just to check in and make sure that you feel supported and you have somebody to talk to about anything you need to. And then the usual 6-week postpartum visit, that's when we do a full physical exam. We check your breast, your belly, your pelvis, your vagina to see if it's healed well with the stitches, or even if you didn't have any tearing, we like to kind of check your pelvic floor strength and all that. And then physical and emotional changes, just to review. Physical, we've talked about all that. So bleeding, uterus contracting to reach the pre-pregnant size, that usually takes up to 6 weeks, but which is why that's when we do the 6-week postpartum visit, the physical at that time, because we're expecting there, when we do that physical exam and we check to see the size of the uterus, we should feel a pre-pregnant size uterus. There's lots of diuresis is peeing, and diaphoresis is sweating, because they're in pregnancy. You all probably know that you're accumulating and your body is making a whole lot of blood volume. So all that needs to come out. There is just a shift in all that volume, and you pee it out and you sweat it out. So you may wake up in the middle of the night and all your sheets are drenched in sweat, and that can be totally normal. So blood volume returned to normal, and there's obviously that hormonal shift where we see the emotional changes. Can be the postpartum blues at first, and then we monitor it to make sure that it doesn't become anything worse, meaning postpartum, all the postpartum mood disorders. It's not only postpartum depression, it's postpartum mood disorders. It can be anxiety, it can be depression, it can be lots of other things. So relying on a support team and provider for help, we definitely want you to rely on us and call us with any question or any concern. Call us sooner rather than later at any time. This is what we're here for. We get all this prenatal care and we see you so frequently during the pregnancy, and then you just get the 2 visits postpartum. That doesn't make sense. So we want to be there for you when you're recovering postpartum, definitely not unrelated to those 2 postpartum visits. There's a lot of changes that you need to kind of accept and grow into, which is accepting your new role as a parent. It's grieving the loss of a previous identity for some. It's feeling isolated, even though you know that there's a lot of women that are going through what you're going through, and maybe you can join some support groups and mommy and me groups and things like that. But sometimes when you don't reach out and you're at home and you're sleep deprived and there's so much going on, this isolation kind of kicks in and you feel all alone. And when you don't talk about it, then it starts kind of weighing more and more on you. So really the key thing and the most important thing is to talk about whatever you're going through with your support person, with your family. And if you don't have that, or in addition to that, with your providers.